We'll be discussing about lasers. Structure of the laser is made of silicon dioxide, the core, and there are layers of that as well, which we see that fine thread, and it is end firing, side firing, and it should be handled carefully. And what are the precautions that you should be wearing? You should be wearing a goggle, especially green light. It is very dangerous for eyes. Laser operators should be knowing what all the people present in that room should be knowing what are the precautions, and doors should be locked, and fiber integrity should be checked, and regular training should be done for lasers, that is it working properly or not. So we'll be discussing types of lasers. There are multiple types of lasers. This was a slide which I showed you. This is a very important slide. This is the wavelength on which different lasers work. This is the highest, CO2. Holmium stands over here, and KTP. Urology has got two main, three, now you can say three: KTP, holmium, and thulium, if I pronounce correctly. So the wavelength of holmium is 2100, and some people say it is 2150, and KTP is 532. We'll be discussing these all lasers in detail. So we'll start with ruby laser. It is the first visible laser produced by a synthetic ruby crystal surrounded by a flashlight. The laser produces red light at a wavelength of 694. The crystal properties degrade with high temperatures, therefore it is best used at low repetition surgeries or procedures. And it is less efficient because we have got more modern lasers. So it was the first laser in 1960 which was used, and it can be used in continuous and Q switched mode. Q switched mode is a mode in which small fast pulses are generated. There is a continuous, there is a slow, and a Q switched mode. So Q switched mode can be used in this as well, and it is very well absorbed by melanin, and that is why it is used in for removing cutaneous lesions on the skin and removing hair and perineal skin during erythroplasty as well. CO2 laser, which we showed in you in the slide, that has got highest spectrum, 10,600 nanometers, and it is visible with helium neon beam for guidance because it is such a high frequency laser. Its beam is highly absorbed by water, therefore it vaporizes water dense tissues at a superficial depth of 1 millimeter. The principle of laser is that it how it gets absorbed. So initially, I told you yesterday as well that it started with hemoglobin. They used to do the use it on the atherosclerotic lesions, and then they've mixed it with saline, and then now water was used as a medium, and it gave very good results. And a waveguide tube can be used during laparoscopy. This can be used. ND-YAG laser. The beam is 1064 nanometers, and it is near infrared. The phones which had infrared, the beam which we showed, this has got a low beam, so that is why this is less dangerous. It can be used at continuous, pulsed, and Q switched mode. Everyone has the idea now of Q switched mode. Small bursts with, so 1064 nanometers is the wavelength, and it can be dissolved in hemoglobin and absorbed in hemoglobin and water as well. So it can be used for both. The reason why we are discussing hemoglobin is that yesterday we discussed argon laser, that it has got good penetration through hemoglobin. Same goes for YAG as well. It has got good hemostatic properties, so it coagulates blood vessels very well, and it can be used for cutting and suitable for stone removal as well during lithotripsy. So YAG is the most commonly used crystal, which why it is used most commonly because its efficiency, optical quality, and thermal conductivity, which permits that you can repeat it continuously for more time. Otherwise, it can be damaging for the tissue as well and the machine as well. So an optical fiber is used to delivery, which may be passed through all types of endoscopes. This needs to be addressed as well, that can that laser be passed through the, because these instruments are expensive and very delicate. Now the FRs are decreasing, the size of the scopes are decreasing. So can this be easily utilized or not? When we are doing RIRS or any laser tripsy, then we need to keep that laser fiber outside that scope, If you bring that inside the scope, it will damage the lens and the telescope and everything, and that will be uh, dysfunctional, and you cannot use that again. So the laser fiber, that tip of the fiber has to be outside that ureteroscope or any instrument which you are using. So it has got a sapphire or a crystal tip which allows precise cutting using a direct touch technique, and may also be used as an optical fiber. What is a direct touch technique? Ravi, touch technique and non-touch technique. You have any idea about it? Talk in English, please. बोले बोले बोले.
Sir, in touch technique, we place the fiber
in contact with the target
contact with the tissues, then fire, and non-touch, we keep it up far apart.
In
Spark.
which thing you will touch it and in which thing you won't touch it?
Sir, in stones.
In stones, there is an effect called popcorn effect. You keep far away and you flash it. We'll be showing you the video and discussing it. That is a non-touch technique. But if you go and bust and dust and put the laser inside, make a hole and then fragment it into pieces, that is a touch technique. So that is a non-touch and touch technique. So Nd:YAG laser, it is a low power, low cost laser developed for intracorporeal lithotripsy, and mainly we use holmium, not YAG, because it is expensive as well, and it has got a part of Freddy laser in which you can mix it with the KTP part. So now we'll be talking about KTP laser. It yields green visible light at a beam of 532 nanometers, and by passing a Nd:YAG beam, it can be combined with it for 1064 nanometers through KTP crystal. There are two components, the crystal and the particles, which we showed you in the slide. You all have that concept now. So the crystal in this is KTP crystal. A lot of blank faces. सही तो है, सबके लिए सही है. So the light penetrates less than Nd:YAG because of its shorter wavelength and is absorbed by hemoglobin. It is used for incisions, resection, ablation, and can be passed through optical fiber. So the flexible instruments, these things can be used. One disadvantage of KTP laser energy is that tissue carbonization is observed rather than true ablative effect. Carbonization is that the tissue gets charred and you think that you have controlled the bleeding or whatever you are doing. A false effect is being given, that is called carbonization. True ablative effect is not given, so that is a big disadvantage, but still people use it. So dye lasers, lasting medium is organic liquid dye that must be excited optically by another laser or a flash lamp. Wavelength emitted depends on type of dye used, and therefore it can be turned into wide spectrum of light according to the dye. It can be used in pulse modes, and the laser is used for lithotripsy and ablations of vascular lesions. The most common dye is chromium, and it produces a wavelength of 504 nanometers when excited by a flash lamp. As opposed to a solid state laser, a dye lasting in the chamber requires replacement. Regular replacement is required and is inconvenient and inexpensive. That is why it is not used. So there are multiple types. We are discussing advantages and disadvantages of every laser, that why holmium got publicity and why it is most frequently used and why others are not used. That is why. Alexandrite laser, it is commonly it is composed of chromium doped mineral alexandrite and a wavelength of 380 to 830 and the strongest at 700 to 800 nanometers. Light is absorbed well. Melanin as well is absorbed. This one is also used for cutaneous lesions. At 1 ms pulse mode delivered with an optical fiber, it is used for lithotripsy of pigmented stones and can be combined with indigo cyan green dye for tissues and for welding of the tissues. Semiconductor diode laser. Laser light is produced by light emitting diodes LED between reflecting mirrors, and they are smaller more efficient, potentially cheaper than most of the lasers used. Their wavelength can be tuned by adding various elements, aluminum and indium. These lasers are currently used for tissue coagulation and thermal treatment of solid organs like prostate. In this setting, the laser energy is delivered to the tissue with optical fibers and it increases the local temperature. Benign prostate tissue is affected, and as the denatured protein is reabsorbed over time, the bladder outflow obstruction decreases. This is an advantage. Nitrogen laser, again, nitrogen gas is used in it as a lasting medium, and when excited, it gives a wavelength of 337 nanometers. This laser has been studied as a component of diagnostic tool for transitional cell carcinoma and mucosal malignancies as well. For mucosal malignancies, quartz optical fiber is used and fluorescent light is produced, which is transmitted back to the system, and this is how it works. This is the most important and most important for urologists, holmium YAG laser. It is a recent addition. I told you that few people say it has got a wavelength of 2100 and few people say it has got a wavelength of 2150. So it depends. YAG is the crystal, holmium is placed over it, and the laser energy delivered most commonly in a pulse style manner using a thermomechanical mechanism of action. It superheats water, which is heavily absorbed light energy at this wavelength, and this creates vaporization bubble at the tip of low water density quartz or silica fiber used for delivery, and the vapor bubble expands rapidly and destabilizes the molecules that it contacts. Anybody has got idea about bubble? What is this bubble formation?
Into the tissue, the water is converted into the vapors, bubbles, and this bubble, the rapidly expansion and collapse of this bubble then create some effect on the uh, tissue ablation.
Fragmentation.
Yeah.
So when you're fragmenting the stone, so this mechanism works that there is a bubble formation and it goes and collides and fragments. So our main topic is Moses technology. We'll be discussing it, that how this technology differs from Moses technology. Phenomena. There are two things. There is a effect, Moses effect, and a Moses technology. We'll be discussing that what they thought, that why that energy is not going properly over there to the target tissue. It is ideal for lithotripsy. We all know depth of absorption is 1 to 2 mm as long as it is used in water-based medium. The specific light energy provides good hemostasis when used in pulse mode, 250 ms duration and low pulse rate repetition. At higher repetition rates, it can be used for incisions as well. Lithotripsy, incisions, and or hemostasis. This is how the machine looks like. This is the holmium YAG laser machine, and these are the applications: stones, intracorporeal lithotripsy, prostate, HOLEP. HOLEP stands for NER5. जी जी बोले बोले ए 1% at a time.
Holmium laser enucleation of prostate.
Yesterday you saw the slides, the videos as well. Bladder tumors and urethral strictures. Holmium laser provides different modes and settings, and we discussed that contact and non-contact. You touch it, how do you fragment it, and so dusting, busting, and painting and popcorning effect. We'll be discussing about the settings of these.
The holmium YAG laser is a solid-state laser made with the rare earth element holmium in combination with a yttrium aluminum garnet crystal. It operates at a wavelength of 2100 nanometers, which falls in the infrared spectrum and is therefore invisible to the human eye. The laser energy is transmitted via a flexible silica fiber with a diameter ranging from 200 to 400 microns when used with a flexible ureterorhinoscope. The fiber should always be visible for the user in order to protect the endoscope from damage. Energy and frequency settings can be adjusted via the user interface. High frequency 20 Hz and low energy 0.2 joule result in a dusting effect on the stone. The stone dissolves into stone dust, leaving almost no larger fragments behind. The surgeon should work from the outside to the center of the stone. Low frequency and higher energy from 0.8 to 1.2 joule fragment the stone. The popcorn technique disintegrates multiple fragments by using their movement in the collecting system.
So now a bit about Thulium YAG laser. This is a new laser as well, and it provides high power laser emission as well. Holmium had 21 and it has got 2010 nanometers, widely used for surgical cutting and coagulation. And now there is a comparison going on between holmium and tholium for stones as well. Dr. Oliver, whose article we'll be discussing, gave a talk in Hyderabad this year, and he discussed about this laser that this can be the future of stone fragmentation as well, because it has got all those properties which are favorable. But I'm not sure that he said one thing, that it is used in only two countries, India and another country. I guess because of some nuclear restrictions. I don't know what was the reason behind it. So if anybody knows.
Basically, it was originated in Sweden, Stockholm. So actually, holmium, the first three letters or four letters stand for Stockholm. So home and holmium. Same goes with thulium. Thulium again is the older
Scandinavian.
name. Yeah, it's the same. It's the older name of Scandinavia or Scandinavian countries. So basically, these are the two countries where it was actually approved for human application. One is Sweden, the other one is France, and third one is India. France, because Oliver Trexler is actually a French person, and he's the president of Endourological Society these days. So these are three countries actually.
Both lasers, holmium and thulium, are ideal for endourological applications as they are completely absorbed by water, and it has got a tissue penetration of 0.4 mm. Holmium and 0.25 mm is the tissue penetration of tholium. So a bit about, briefly we'll be discussing about uses of laser in urology. So BPH is a very big name which is coming in endourological procedures, and every day new technology is coming to how to use new technology, and TURP, which is the gold standard, will be, I guess, beaten by these technologies, because when TURP came, so open prostatectomy was the gold standard, but TURP took over. So holmium, you can now what does this mean? HOLRP. Resection of prostate. This is E, A, and vaporization. KTP, LBO. This is photoselective vaporization and enucleation. Thulium, again A, same things, and diode laser. In stone, you can fragment it intracorporeally and using a flexible or semi-rigid. We did a lot of RIRS cases over here, and we used a semi-rigid. That is a semi-rigid, which the URS which you use is not rigid. That is a semi-rigid URS, and we used to go to the pelvis, and we used to place a guide wire laterally that the stone doesn't fall in the calyces, and then we used to fragment it with the laser we had. But now newer technologies have come. Now it's time to go to flexible, and flexible URS first, or RIRS. What does RIRS mean? Retrograde intrarenal surgery. So a lot of research is going on in lasers. The upper and lower tract TCC, if the lesion is small and this is solitary kidney, so no need to do a nephroidectomy, use it, ablate it with the laser. I'm not saying that it's gold standard, that is under research, and people do that for selected number of cases, less invasive tumors or less than 2 centimeters, solitary kidney, patient's wishes, multiple things. You can use it. Lab MRI guided laser ablation of small RCCs, prostate cancers, tissue welding, penile cancers. We have seen lasers being used, and genital lesions like condylomata accumulata. So a bit about laser settings. This is very important, that energy into, which is in joules, into frequency which is in hertz, equals to watt. Initially the lasers which came were of 10, 20, 30 watts. Then 60 watt was the gold standard. And after that, when 100 watt came, it revolutionized things. Now 120 watt has come. So the prostate which we do, the prostate settings, we need 100 watt settings for the prostate. And for stone, we can go to 15 maximum. Starter settings is 2.5. This is 0.5 joules into 5 hertz equals to this 2.5 watt. But you can extend it to 15. A few people use it on 17 as well. We'll be showing you the. So this about this, these are the settings of dusting, fragmentation, and popcorn effect. In popcorn effect, that is a non-touch technique. You don't touch it. Long pulse, low energy, high frequency. That will make the stone dust. Fragmentation, short pulse, high energy, low frequency. And over here the frequency, the watts is 7.5 to 10, 7.5 to 10, and over here 10 to 17.5. So people are going towards 17.5 as well. So in popcorn effect there is long pulse, high energy, low frequency. These are the things, when we start doing it, then we understand, and then we remember, and then we say. But newer machines have got fixed settings that you put, that I want to do a popcorn effect, it will automatically change the settings and you can do it. In the laser we had, which we used, we had to do manual settings, that I want high energy, low frequency, and things like that. But newer lasers, things have become simple.
So if you go back to the last one, the last slide. Yes, this one. You see, these are the three different parameters, energy, frequency, and power. But these are the three cardinal steps. For instance, if you want to overcome something which is as hard as a stone, in comparison to something which is as soft as a prostate or a bladder growth, then these are two different ends of spectrum, and these are two different things which can oscillate as a result of the power or energy that you use. But in order to break something with a particular power, if you increase the frequency, you can break it. You go back to the Doppler effect, you go back to the physics of FSC, when the marching soldiers was actually marching through a bridge, and a hanging bridge. So if all the footsteps of the soldiers fall in, together in unison, that will increase the frequency, and that can break the bridge. So the same goes with stone fragmentation as well as with ablation of prostate. So we have to think of watts versus frequency versus energy. So these are three different parameters. You can change them, you can manipulate them, but then in order to have a effect, you can have greater frequency with lower power or more power with lower frequency. So that's the thing.
So he's dusting now with 10 watts, 0.2 joules, 50 hertz. These are the settings of an expert. The previous slide had 100 watts. It depends on how confident you are, but you should be starting with low settings.
And sometimes when you do something like this, this procedure, you always rely on your technician to do something for you, but that shouldn't be the case. If you understand the physics properly, then you are actually the operator, and the onus lies on you, Because if, for instance, this thing vibrates, as you can see, there is a to and fro vibration of the tip of the laser instrument. And if that vibration is not controlled properly and you have got a very high frequency, then you can damage the mucosa, which are on the sides all around. So this is very important because you have to calculate something on your own rather than relying on your technician. So that is why it is important for a urologist to understand physics if he or she wants to use energy.
And another point that when you are using these kinds of performing these procedures, the water is very important. The water, which is the saline, the irrigation, the fluid which is going on, is very important that it gets absorbed, and the pressure. We didn't discuss about the pressure because a lot of RIRS and flexible which are being done for the stones, a lot of people place a ureteric access sheet. They place a DJ stent 4 to 6 weeks before the procedure that the ureter dilates, and then they place a ureteral access sheet that the intrarenal pressure it reduces. And when we used to do RIRS with a semi-rigid, you don't use a ureteral access sheet in semi-rigid, you use it in a flexible. And when we used to do it, so we didn't have flexible access to the flexible, so we used to do it with a semi-rigid. So what we used to do when we used to go to the stone, we used to reduce the water to as minimum as possible that we can only see the vision, and when the vision used to get blurred, we used to open it up the channel and then again close it, because two of our patients initially when we started had perinephric collection of around 100 ml, because that kidney bursted because of that excessive increase in intrarenal pressure. And so that is a very important lesson, that while doing these procedures you have to keep an eye on the uh, water bottle which is hanging.
Second thing is when you start fragmenting a stone, Mandu Sahab is there and Murli Sahab is there, they will bear me out. You always start from the periphery. You don't start from the center point. Otherwise, you will be creating 2 or 3 larger fragments, and then each fragment has to be taken on separately. If you start from the periphery, you will have a lot of dusting, and then you move on to the harder part, and that is in the middle. You have got lesser amount of tissue or a stone that has to be broken down. Always start breaking the stone from the periphery rather than from the center.
You're right.
Yeah.
But starting at periphery, you have to take care of the mucosa.
Yes.
Because in the middle you are comfortable, because you are feeling that you are in the middle of a stone and mucosa is away from your fiber.
But if you go back to
yes.
this video, he has taken a little rim
Yes.
at the periphery, and he's not actually in the center, but rather away from the center.
Away from the
A lot of people do that. They make a hole in the center. They are fragmenting and dusting, whatever they are doing. They make a hole in the center, and then they realize that the laser fiber is not coming outside, and it fragments in larger stone fragments. So you need to do it in a painting manner if you are painting like this, or like dusting. He has shown our popcorn effect, but the basic principle is that there are two things: either you have to remove that stone completely, or you have got a flexible, you have got a urethral access sheet, you have got a basket available, you fragment into large stones, there is a large stone, you take out with the basket all the stones. The other is that it is a small stone, ESW refractory or lying in the calyx, difficult anatomy. That stone, you can't take it out completely, or there is some problem, so you dust it and leave it. That will come out the very next day. What is the time period after these procedures you will label a patient stone free? How many days, how many weeks? You'll ask the patient to follow up. We ask the patient to follow up. Next day we get an ultrasound done. There are a lot of residual stones, and we label him as a residual stone patient, and the next week we call him in our clinic. What is the ideal time that you should be seeing a patient with RIRS or a flexible ureteroscopy patient. 4 to 6 weeks is the time. So you get an ultrasound done. I am not saying don't get it done. Get an ultrasound, X-ray, whatever you want to do, but label him as a residual stone patient after 4 to 6 weeks, because these fragments keep on falling and nobody clears completely. So we need to label it 4 to 6 weeks. Any questions or any queries to the moment, because now the dry topic starts. The Moses, the Moses technology and a lot of basics. Yes.
You have mentioned theory, dusting, fragmentation, and popcorning. So, what are indications for those? Dusting is the ideal one. If you get it, then it's okay. Patient will be stone free within no time. But when to use fragmentation and when to popcorn?
All, sir, operator dependent. All the things depend on what you like to do. If it is a small stone, people fragment it into large pieces and they remove it with basket. If it is a large stone, a few people do the same thing. But it depends on the operator, what facilities they have available. They have access sheet. They have what do you say, basket available or not. If they have a basket available, they fragment into large pieces. They pull out the pieces and complete the procedure early, because dusting, painting takes time. If it is a large stone, you need a 1 hour to fragment that stone completely, and so it depends on the operator, the timing, and the facilities available. There are no clear indications mentioned anywhere that for this stone you have to do this. So these technologies have been made that if you find you have less things in your armamentarium, so you can utilize them.
Size
properly.
of stone is also,
Yeah.
I think, important.
So now, any queries? Anything you didn't get? G. Sir, there are two techniques, touch and non-touch. We discussed contact or non-contact to be precise. And in popcorn effect, you don't touch it. In dusting, you slightly come closer, but while fragmenting, dust and bust. So you go and in bust, you go and touch the laser and fragment it. So it's all operator dependent that how you want to do it. At times you what we in our, because I've done a few cases, so while you are fragmenting it with the painting and dusting, you're doing it very well and you're doing it, and it goes half an hour, and there is a lot of pressure that you need to get next case done, or the patient irrigation fluid is being used as well, so you start busting it, fragmenting it into large pieces. So it's all operator dependent. I guess if you have time, armamentarium available, then I guess everyone should go for painting or dusting, because in that all the residuals will come automatically. No. Ji, sir. So what is Moses effect? It has got a very huge history behind it. So we'll be discussing it. Since the first urological application in 1992, holmium YAG laser has become the main player among lasers currently used. Why? Because of its effectiveness. It is effective. It is cheap compared to other things which are available, versatility and safety profile. Safety is very important during the procedure, post-operative. The most important thing is safety. So it is safe compared to others. In endoscopic laser lithotripsy, holmium YAG laser is superior and gold standard at the moment. But the need for more efficient laser tripsy is promoted, and research is going on new laser fibers and improvement in energy and fragmentation and other procedures. Urological lasers work by definition immersed in a liquid fluid environment. We will be discussing it that initially it started with the blood medium, but now it has come to the water medium, and it has got advantages and disadvantages. The laser beam reaches the target, will be partially delivered if the fluid is not compatible with the laser and the environment. The formation of vapor and bubbles at the tip of the laser, through which the laser pulse may travel directly to its goal, has raised considerable interest in research community and was named Moses effect. This bubble phenomena which we discussed was labeled as Moses effect in 1986. Although Moses effect has been known to exist since more than 30 years, it was first like in 1970s it was discussed, but in 86 it was implemented. Recently, this mechanism has begun to gain some glimpses of popularity in the endocrinological community with the recent commercial introduction of Moses technology. So that was Moses effect, and the technology which we'll be discussing is Moses technology. So what is Moses effect? Which you told us that is the Moses effect. So a lot of database was seen from 1988 to 2018, and in which the keywords were Moses effect, OR technology, lithotripsy, stone, BPH, prostate, all were searched. 675 articles were taken out of which recently published in 10 years were 543. And out of those 543, 415 were not in English or editorial or letters only. So remaining were 128. And out of those 28, there were duplications and non-relevant to research, so they were also discarded. So in the final study of this case, only 12 articles were of some importance. So a brief history about laser. We have already discussed this about the flash pump. People who are not present, we'll recap it if we have time in the end. And these things we have discussed again. So why we have got this in the slide, because first we were generally discussing lasers and now we are discussing this article. So this article is repeating the concept of how the laser works. So the origins. In 1986, we discussed Moses effect. This is the first report that came was in 1986 at a conference of communication. It was communicated in that conference, and it was used for intravascular ablation of atherosclerotic lesions. Dr. Bilal, you dilate those veins. How you have any idea about laser technology being used recently or not?
I read Moses effect yesterday, actually.
So you use the traditional.
Yes, we use the balloon dilatation in our cases, but actually the formation of bubble is the result of Moses effect. What is the Moses effect? Is the dispersion of water when a magnetic field is exposed to that charged liquid. So that is the Moses effect, named after the Moses.
वो आएगा अभी पिक्चर आ रही है, आपसे हिस्ट्री हम पूछेंगे जरा.
हिस्ट्री सबको पता है तो बहुत बच्चों वाली बात है.
नहीं उसकी थोड़ी डिटेल से.
So when I started reading Moses effect for the very first time, maybe 1 year back or 1.5 years back, I thought that it was discovered by somebody called Moses Socarius, because he's the one who is in the European Urology Association and somebody who is of my age, perhaps. But it wasn't. It was something which was originated from the biblical era, maybe 3,000, 4,000 years back. We'll see what it is later.
So after 86, then in 2 years later, in 1988, Isner and colleagues hypothesized that the formation of dynamic optical cavities, vapor channels serving as a pathway for transmission of laser pulse. So they again went a bit further. So this is a picture which shows Moses effect and Moses technology. And I'll be showing you the video at the end, so you'll be getting a much better idea about it rather than. So the basic principle is that in 1988 they discussed that laser fiber makes vapor channels and the bubble phenomena was observed. These observations were initially carried out in blood composed mediums, and it demonstrated that these vapor channels enabled the transmission of laser energy over a longer distance in liquids than expected from the optical penetration depth. So this is the technology why it was named Moses. Dr. Bilal, आप please थोड़ा बताएं.
So I think it shouldn't be Bilal. It should be everybody else. This was something which was happened many thousands of years back by Hazrat Musa alayhi salam when he led Bani Israel because of the wrath of Pharaoh, and he led through the river Nile, Red Sea. So it was River Nile or Red Sea, whatever, but it was some river.
Red Sea.
And what he did was he threw his asa on it, and whole water was actually diverted away, and there was a clear path for everybody to walk through, and then everything was then settled down again, and they were saved. This was actually Moses' effect. What gave us a clue in this day after many years is actually the phenomena of or the question that when we apply force on any medium, there are two things. One, we want to have a linear pathway for that application to go towards a tissue which we want to ablate or disintegrate. What happens is when there is fluid medium in front of a laser, for instance, or maybe electrical current or magnetic field, it disperses. In order to make it more linear or targeted, this is the effect which is already there. What happens is all physics, and we'll see how it happens.
Any queries? So it was observed that this transmission which goes in, they tried it in blood and saline mixed, 50 saline and 50. Initially started with blood, then they divided with 50 blood and 50 saline. So they saw that there is a increase in transmission, 10% increase in transmission of the energy. So suggesting that the micro bubble flow created a dynamic channel in the blood saline solution through which the laser radiation was transmitted. In 1989, despite these promising early findings, only a few reports later discussed Moses effect with rather slow spread in both clinical and research settings. So later advancement described how bubble formation, expansion, and collapse occurred. Because of the generation of these acoustic transient shock waves, theoretically capable of interfering and damaging the newer technology. That is why in 1989, after that, the Moses effect and research on this technology declined because of the damage to the nearby tissue. They thought that if we'll use this technology, it will damage more rather than it will give benefit. So that is why it declined in the early 90s and late 80s. Towards the application to urological procedures, Van Leeuwen and colleagues focused that there is a holmium YSSG laser for non-contact tissue ablation, better characterizing the Moses effect in blood and saline medium, and it has got good pulse duration, tissue penetration, characteristics of vapor cavity. But this was again not used because of the effectivity, safety profile, and all those things. If it was expensive as well, so they later withdrew it. Later researchers moved to holmium YAG lasers, and the wavelength output of holmium YAG laser is highly absorbed in water with a consistent decrease in amount of energy to the target tissue. As explained, the part of energy absorbed by the water results in creation of vapor microbubbles. Once these bubbles reach the target, the laser beam can pass through with a very little attenuation, since the density of water molecules in the steam is considerably low in liquid phase. So that is why they shifted from blood to 50-50 saline and blood, and then to the water. The kinetics of bubble formation is 100 to 200 microseconds, and in order for the YAG laser to perform the pulse. You will understand this concept after these slides, 2-3 slides. I'll show you a video, and then you will get the concept what goes on. The formation of water bubble can be triggered by a very small amount of laser energy, and the speed at which the bubble form and is relatively independent from the duration or the energy of the pulse. The actual characterization of amount of energy needed to create the bubble made it clear that the laser pulse could be effectively optimized in order to achieve the best delivery of energy to the target tissue.